Hi, everyone. Today we're going to talk about fluid regulation. One of the key concepts in nursing, very important due to the fact that we do intake and output. We monitor daily weights. We try to see if the patient is dehydrated, not getting enough fluids, and sometimes we have to assess after treatment if the patient is getting too much fluids. So the learning objectives for today is to describe the body fluid compartments and explain the movement of water and solutes by osmosis and diffusion. Tell the difference between hypovolemia and hypervolemia, including like the causes, clinical manifestations, and what is our nursing responsibilities and priorities. Compare crystalloid and colloid IV solutions, such as isotonic, hypotonic, hypertonic fluids, and to identify appropriate clinical uses. Then you will also check your labs to see if the patient has enough fluid balance. You'll check CBC for their components and apply blood transfusion principles to patient care. You'll also apply fluid and electrolyte concepts. Very basic, because this is all about fluids for now. Electrolytes will be done separately, because if I did all together, I think everybody would just go crazy. So let's get into it. So electrolytes are minerals that carry an electrical charge when dissolved in body fluids. They're found in the blood, urine, tissues, and inside and outside our cells. The four major electrolytes we'll focus on for this semester will be sodium, potassium, calcium, magnesium. These electrolytes are essential for nerve impulses, muscle contractions, maintaining fluid balance, heart rhythm, and acid-base balance. We obtain them from our diet, and the kidneys work continuously to regulate their levels. As nurses, recognizing electrolyte imbalances early is critical because they can quickly lead to serious cardiac issues, neural issues, and muscular complications. Electrolytes do more than maintain fluid balance. They help regulate how much water stays inside and outside the cells. They maintain the body's acid base or pH balance and allow nutrients to enter cells while waste products leave. Most importantly, electrolytes generate the electrical signals needed for muscle contractions, nerve transmission, heart rhythms, and brain function, especially with sodium. If there's not enough sodium in your blood, that causes your body to cause more issues with neural status. So once you understand that, it could cause confusion. You could understand that maybe sometimes if it's not an issue with oxygenation, you would have to check what is going on with the electrolytes. To understand fluid regulation, we first need to understand where water is stored in the body. About 60% of the adult's body weight is water, and it's divided into two main compartments. Intracellular fluid, which is fluid inside the cells, it contains about two-thirds of the body's total water, making up approximately about 40% of body weight. This compartment is rich in potassium. So potassium is mostly intracellular. Phosphate is also there and proteins, which are essential for normal cell function. The remaining one-third of body fluid is in the extracellular fluid, or ECF, which is the fluid outside the cells, making up about 20% of body weight. The most electrolyte that you'll see extracellularly will be sodium. Sodium has a partner and it's called chloride. And you'll also see bicarbs, and it's divided into two parts. So extracellular has two components, intravascular fluid or plasma, which is the fluid inside the blood vessels, and it makes up about 5% of your weight, and it transports oxygen, nutrients, hormones, and waste products throughout the body. The second is interstitial fluid, which is the fluid between the cells. It makes up about 15% of the body weight. and it surrounds, nourishes, and protects the body tissues. Water is constantly moving between these compartments by osmosis, traveling toward the area with the higher concentration of solutes, which means whatever components that is, they want to maintain it, to balance it. As nurses, understanding these fluid compartments help explain dehydration, edema, IV fluid therapy, and electrolyte disorders. So remember, ICF, inside the fluid, ECF is extracellular, is outside the cells, intravascular is in the blood vessels, interstitial is the spaces between the cell. All right, so osmosis versus diffusion. What is it? You need to understand it though. How do water and electrolytes move between these compartments? Two key processes make this happen, osmosis and diffusion. Although they sound similar, they move different things. Osmosis is the movement of water, while diffusion is the movement of solutes. Solutes, an example would be oxygen, carbon dioxide, or electrolytes. Understanding these two concepts will help you explain IV fluids, dehydration, edema, and electrolyte imbalance you encounter, especially on the nursing floor. Diffusion and osmosis are both passive transport mechanisms, meaning they don't require ATP or energy. The key difference is what they're moving. Diffusion is the movement of solutes or particles from an area of high concentration to low concentration until they are evenly distributed. Think about spraying perfume in one corner of the room. The fragrance molecules spread throughout the room without anyone moving them. In the body, oxygen diffuses from the lungs into the blood, while carbon dioxide diffuses from the blood into the lungs to be exhaled. Osmosis, on the other hand, is the movement of water across a semi-permeable membrane. Water always moves from an area where more water and fewer solutes to an area with less water and more solutes. An easy way to remember this is water follows salt. Water moves toward the higher concentration of solutes to dilute them and create balance. A great nursing example is 3% hypertonic solution, hypertonic saline. Because the bloodstream becomes more concentrated than the cells, water moves out of the cells and into the bloodstream by osmosis, helping reduce cellular swelling, like cerebral edema. When it comes to dehydration, think about what happens when you exercise on a hot day. As your body temperature rises, you begin to sweat to cool yourself down. Sweat is mostly water, but it contains electrolytes like sodium, potassium. If you continue exercising without replacing these fluids, your body loses more water than it takes in, leading to dehydration. As dehydration develops, body volume decreases, making it harder for the heart to deliver oxygen and nutrients to your muscles. You may notice thirst, dry mouth, fatigue, dizziness, muscle cramps, dark urine, and a faster heart rate. If fluid loss continues, blood pressure can drop and severe dehydration may progress to hypovolemic shock. This is why athletes and people exercising should rehydrate by drinking water. And if they have been sweating heavily for a prolonged period, they may also need to replenish electrolytes. As nurses, we assess hydration by monitoring the vital signs, intake and output, daily weights, urine color, and lab values. Early recognition and fluid replacement are key to preventing serious complications. So, you're sweating a lot, you're exercising, you're sweating a lot, you're going to lose water and possibly electrolytes. You decrease your blood volume. You become dehydrated. You need to rehydrate with fluids and maybe electrolytes in order to become normotensive again. So your patient exercises for several hours in the heat and reports thirst, dizziness, tachycardia, and dark concentrated urine. It's most likely that they're experiencing fluid volume deficit or dehydration and need prompt fluid replacement. Another example would be dehydration from blood loss. Another way to understand dehydration is like about significant blood loss after a car accident or surgery. Blood is made up of plasma, which is mostly water, and blood cells. When a patient loses blood, they're also losing a large amount of fluid. From the intravascular space, the fluid inside the blood vessels. As blood volume decreases, there is less circulating fluid to deliver oxygen and nutrients to the body's organs. To compensate or to make everything better to keep us alive, our heart beats faster, but it's too much blood that is lost. The patient may develop tachycardia, hypotension, cool, clammy skin, dizziness, decreased urine output, and altered mental status. If untreated, this can progress to hypovolemic shock. As nurses, our priority is to stop the bleeding, monitor vital signs, assess for signs of poor tissue perfusion, establish an IV access, replace the lost volume. Initially, patients often receive isotonic fluids, such as normal saline or lactated ringers to restore circulating volume. If the blood loss is severe, they may require blood transfusions to replace both the fluid and the red blood cells. So remember, not all dehydration comes from sweating and not drinking enough water. A patient with hemorrhage is also experiencing fluid volume deficit because they're losing fluid directly from the bloodstream. The nurse's first priority is to maintain circulation and restore intravascular volume to preserve perfusion to the vital organs. Thirst. Think about what happens after you've been outside on a hot day or exercised for a long time. You've been sweating and losing water, and suddenly you become very thirsty. That's why that's your body's natural defense against dehydration. When the body loses water, the blood becomes more concentrated, meaning there's a higher concentration of sodium and other solutes. Specialized receptors in the hypothalamus causes you to detect this change and stimulate the thirst center in the brain, making you want to drink water. At the same time, the hypothalamus signals the posterior pituitary gland to release antidiuretic hormone, ADH. Listen to the word, it's called antidiuretic. So, what do you think it's going to do? It's going to prevent you from urinating. ADH is also called vasopressin. ADH travels through the bloodstream to the kidneys, where it tells the kidneys to reabsorb more water back into the bloodstream instead of losing it in the urine. So it tells your body to stop urinating. So this is why, as nurses, strict I&Os is important. And counting how much fluid the patient had as an output, no less than 30 mLs, is important to know as well. As a result, when you produce less urine, the urine becomes darker and more concentrated. That's why we observe the color and we document that too, because it helps the body conserve water until you can drink fluids. The body has two major defenses against dehydration. One, thirst, which encourages you to drink more water. ADH helps the kidneys conserve the water you already have. Hypovolemia means there is not enough fluid circulating inside the blood vessels. Think of it as the body losing volume from its circulatory system. A common cause is blood loss, such as from a motor vehicle accident, surgery, or even GI bleed. Imagine a patient who loses significant amount of blood after an accident. As the blood volume decreases, there's less blood returning to the heart. So the heart pumps out less blood with each beat, right? So to compensate, the body activates the sympathetic nervous system. That's another lecture, causing the heart rate to increase and the blood vessels in the arms and legs to constrict. This shunts or bypasses the remaining blood to vital organs. So our vital organs are the ones that can't regenerate themselves. That's the heart and our lungs and our kidneys. As nurses, you'll notice that signs as tachycardia, hypotension, weak pulses, cool, clammy skin, delayed capillary refill, excuse me, decreased urine output, dizziness, and altered mental status. If the volume loss continues and is not corrected, the patient can develop hypovolemic shock, a life-threatening emergency. Treatment focuses on stopping the source of bleeding, restoring intravascular volume with isotonic IV fluids, and administering blood products if blood loss is severe. So remember, less volume equals less perfusion. When there is less circulating volume, the body tries to compensate by increasing your heart rate, tachycardia, blood loss constricts, causing the skin to feel cool, pale, right? Kidneys conserve water. You'll see decreased output. Blood is prioritized to the brain and the heart. So the earliest signs of hypovolemia, while hypotension is usually a later sign, indicating that the body's compensatory mechanisms are beginning to fail. So early recognition is key. Let's continue with our patient who lost significant amount of blood after a car accident. If the bleeding isn't stopped, the fluids aren't replaced, the body begins to run out of ways to compensate. At first, the heart beats faster and the blood vessels constrict to maintain the blood flow to the brain and the heart. But as blood volume continues to fall, blood pressure begins to drop and the body tissues don't don't receive enough oxygen. The patient may become confused or difficult to arouse, difficult to wake up because the brain isn't getting enough oxygen, not enough tissue perfusion, not enough blood flow. Urine output decreases or stops because the kidneys are trying to conserve every drop of fluid. The patient develops a rapid heart rate, rapid breathing, weak pulses, cool, clammy skin, and low blood pressure. As oxygen delivery worsens, you may even see blue lips, or nail beds as a sign of severe hypoxia. Without immediate treatment, the patient progresses to hypovolemic shock, where the heart can no longer pump enough blood to meet the body's needs. This can lead to multi-organ failure because there's not enough blood to circulate to the rest of the organs if not treated properly. So think perfusion first. Ask yourself, is the patient perfusing to the brain? Check for mental status changes. Is the patient perfusing to the kidneys? You check your urine output. Is the patient perfusing to the heart? Weak pulses, chest pain, tachycardia. If the answer is no, this patient requires immediate intervention with oxygen, large bore IV fluid access, rapid isotonic fluid resuscitation, control of the bleeding, and blood transfusion if indicated. All right, so at first, the body compensates by increasing the heart rate and constricting blood vessels. But once the body loses about 15 to 20% of their blood volume, those compensatory mechanisms begin to fail, and the patient enters into hypovolemic shock. As this stage, there isn't enough circulating blood to deliver oxygen to the body vital organs. Blood pressure drops, pulse becomes weak and rapid, and the patient may become confused, restless, and difficult to arouse because the brain isn't getting enough oxygen. Like I said before, urine output decreases dramatically because the kidneys is receiving less blood flow. And the skin becomes cool, pale, and clammy. Why? Because it's being redirected. There's vasoconstriction. All the blood is moving away from the skin to save the heart and the brain. I remember seeing somewhere that if you was to cut someone during this time, there would not be any blood to come out because everything is trying to prioritize. This is a medical emergency. The priority is to stop the bleeding, administer high flow oxygen, establish 2 large bore IVs, rapidly infuse isotonic fluids. What are examples of isotonic fluids? Lactated ringers and normal saline. And transfuse blood products if needed. We need to restore circulating volume. We need to improve tissue perfusion. We want to prevent irreversible organ damage. So when you look at this picture with hypovolemic shock, once you understand the concept of fluid loss, you understand why it can happen with a patient with burns. It can happen with a patient with hemorrhage, decreased body fluids when you're dehydrated, severely dehydrated. You have GI bleeding if you vomit, diarrhea too much. When a patient has diabetes insipidus or diuresis, they are at risk for hypovolemic shock. And you as a nurse would need to have to understand what are the signs and symptoms, what do you need to look out for, and how would you quickly intervene. So when it comes to intervening, we replace fluids when a patient cannot drink enough or has significant fluid loss. In these situations, we use IV crystalloid solutions. Crystalloids are fluids made of small particles that easily move between the bloodstream and into the tissues. So we start the IV and it goes into the vessel, not into the interstitial spaces, but right into the intravascular space to kind of like mimic plasma, right? So crystalloid fluids, we classify IV fluids by their tonicity, which tells us how they affect the movement of water by osmosis. Hypotonic solution have less solute than the cells. So water moves into the cells. So when you start an IV, the fluid is going to go into the intravascular space and not into the cells. So if you give them a hypotonic solution, it has less solute than the cells. So the water moves into the cells, causing the cells to swell. These fluids are used when cells are dehydrated, but they should be used cautiously because too much swelling can be dangerous, especially in the brain. Hypertonic solutions have more solute than the cells, so water moves out of the cells and into the bloodstream. This helps reduce cellular swelling, such as cerebral edema, but it must be given carefully because it can overload the circulatory system. And most of the time, these things cannot be done rapidly because it causes too much issues with the brain. Isotonic solutions have been all about the same concentration as the body's plasma. So there is no significant movement of water into or out the cells. Instead, these fluid stays primarily the same in the intravascular space, making them the first choice fluids for patients with hypovolemia or blood loss because they quickly restore circulating blood volume. So imagine a patient who has lost a large amount of blood after surgery. The priority is to restore blood volume. The provider starts normal saline or LR, also known as lactated ringers or ringers lactate. They're both isotonic solutions. These fluids stay in the bloodstream, helping to increase blood pressure, improve cardiac output, and restore perfusion to the brain, heart, and kidneys while the patient is prepared for a blood transfusion if needed. Okay, so when a patient has hypovolemia, trauma, burns, vomiting, diarrhea, or blood loss, the initial IV fluid of choice is usually an isotonic crystalloid because the goal is to restore intravascular volume and improve tissue perfusion before correcting other fluid and electrolyte imbalances. Now let's apply what we learned about osmosis to the IV fluids you will use as a nurse. You're often going to use as a nurse. So crystalloid solutions are grouped into three categories based on tonicity: hypotonic, hypertonic, and isotonic. The easiest way to remember them is to ask yourself, which way does the water move? Let's start with hypotonic fluids, such as 0.45% normal saline, also known as half normal saline. These solutions have less solute than the body cells, so water moves from the bloodstream into the cells, causing the cells to swell. They are used when the cells are dehydrated, such as in hypernatremia, high salts in the bloodstream, or later in the treatment of DKA. Because they move water out of the blood vessels, They can lower blood pressure. So we avoid them in patients with burns, trauma, increased intracranial pressure, or hypotension. Next are hypertonic fluids such as 3% sodium chloride. There's more solute than the cells. Another example would be D5-half-NS, D5-NS, D5-LR, D10W. These fluids pull water out of the cells and into the bloodstream. It increases intravascular volume. For example, 3% saline is used to treat symptomatic hyponatremia. So saline is salt water. If the patient does not have enough salt in their blood, we're going to give them intravascular infusion of 3% saline. So, and also we could use this for cerebral edema because it draws water out of the swollen brain cells. Since these fluids increase circulating volume, we must monitor for fluid overload, especially in patients with heart failure or kidney disease. Finally, we have isotonic fluids like normal saline and LR. These fluids have approximately the same osmolality as plasma, so there is no significant movement of water into and out of the cells. One question you might ask is, if lactated ringers and normal saline are the same, why can't I use this for blood transfusion? Lactated ringers has calcium, which could coagulate the blood. Therefore, saline is the only isotonic solution that you could use. Okay, so one important exception is D5W. While it's packaged in a bag that appears isotonic, once the dextrose is metabolized, it behaves like a hypotonic solution, low tonic solution, allowing water to move into cells. Because of this, it is not used for fluid resuscitation or patients with increased intracranial pressure. So just remember, always assess for fluid volume overload when administering hypertonic fluids, especially in patients with heart failure and renal impairment, because they're not able to excrete the extra fluid. So you always have to watch out for increased volume. Unlike crystalloids, colloids contain large molecules like proteins or starches that cannot easily leave the bloodstream. Because they stay inside the blood vessels, they create an oncotic pressure, which pulls water from the tissues back into the bloodstream. Think of colloids like a fluid magnet. They attract water into the circulation. The most common colloid is albumin. Imagine a patient with severe burns. Large amounts of fluid leak out of the blood vessels and collect in the tissues, causing edema, while the blood vessels become depleted of fluid. Administering albumin helps pull the fluid back into the bloodstream, improving blood pressure and tissue perfusion. Other colloids include dextran and hetastarch, which may be used in certain patients with hypovolemia and shock, although they are used less frequently today because they can increase the risk of bleeding and kidney injury. Because colloids rapidly expand the circulatory blood volume, nurses must closely monitor for fluid overload, pulmonary edema, and changes in the bloodstream and blood pressure. Continuous assessment of lung sounds, oxygen saturation, urine output, and vital signs is essential during administration. Most of the time, I promise you, probably like a good 90% of the time, this is going to be administered in the ICU. But this is basic knowledge that you need to know right now, because some of you nurses will automatically go into ICU. Sometimes it depends on the facility that you go. Now, let's review one of the most commonly ordered lab tests, the CBC, also known as a complete blood count. A CBC gives us important information about oxygen delivery, infection, bleeding, and clotting. Let's start with the red blood cells, or RBCs. Their job is to carry oxygen throughout the body. If the RBC count is low, the patient may have anemia or blood loss. If it's high, it may indicate dehydration or chronic hypoxia. Next is the hemoglobin, the protein inside red blood cells that actually carries the oxygen. Think of hemoglobin as the oxygen transporter. Low hemoglobin means the blood cannot carry enough oxygen to the tissues. Hematocrit is the percentage of the blood made up of red blood cells. A patient with blood loss or anemia will have a low hematocrit, while a dehydrated patient often have a high hematocrit because there is less plasma and blood becomes more concentrated. So a nice way that I usually tell my students to remember hemoglobin and hematocrit. If you know the hemoglobin, you're going to definitely know the hematocrit because hemoglobin would be one number, and if you multiply it by 3, you'll get the hematocrit, or around about that same. Notice there's a difference between males and females. Females, hemoglobin hematocrit is fairly lower due to the fact that females menstruate. So if you see a male that's anemic, he either has a GI bleed or an underlying condition like chronic kidney disease that would cause him to become anemic because men do not naturally menstruate. All right, so when it comes to the white blood cells help us identify infection or inflammation. A high WBC usually suggests the body is fighting an infection, while a very low WBC puts the patient at risk for infection. Finally, last but not least, platelets. It helps form blood clots. Low platelets increase the risk of bleeding, while very high platelet counts can increase the risk of a clot formation. It's important to look at platelet counts before you administer heparin, because heparin actually causes you to have thrombocytopenia or low platelets. Okay, let's get back to our patient who's in a car accident and lost a lot of blood. You initially gave him normal saline and lactated ringers to restore the blood volume, but the IV fluids alone do not replace the oxygen-carrying cells that were lost. That's when blood transfusions become necessary. The most common blood product is packed red blood cells, or PRBCs. PRBCs contain mostly mostly red blood cells whose primary job is to carry oxygen to the body's tissues. They are given when the patient has significant blood loss or symptomatic anemia. So the definition of symptomatic anemia is like chest pain, shortness of breath. Okay? Think of PRBCs as replacing the oxygen trucks that were lost during bleeding. If the patient loses a massive amount of blood, they may receive whole blood, which contains red blood cells, plasma, platelets, and clotting factors. Whole blood replaces blood volume and blood components, making it useful in severe trauma and massive hemorrhage. Another important product is plasma, the liquid portion of blood. Plasma contains clotting factors that help stop bleeding. It's commonly given to patients with coagulation disorders, liver disease, and massive bleeding when clotting factors have been lost. We have platelets whose job is to form blood clots. Platelets are transfused when the platelet count is very low and when a patient is actively bleeding and cannot clot effectively. This could happen especially during chemotherapy, major surgery, or trauma. So here's another scenario. Imagine your trauma patient has a blood pressure of 80/50. The hemoglobin is 6.5. What's the hematocrit? Correct. Multiply that by 3 and you'll get the hematocrit. Active internal bleeding. The nurse first starts normal saline to improve circulation. However, because the patient has lost a large number of red blood cells, the provider orders packed red blood cells to restore the oxygen delivery. If lab studies also show abnormal clotting, the patient may receive plasma. If the platelet count is low, platelets are added to help stop the bleeding. Okay, we discussed the need for blood transfusion. Let's talk about who can safely receive which blood type. Given the wrong blood type can cause a life-threatening transfusion reaction. So compatibility is critical. Blood types are based on two systems: the ABO system, which is A, B, AB, or O, and the RH factor, positive or negative. Think of the red blood cells as wearing name tags called antigens. If a patient receives blood with a name tag their immune system doesn't recognize, the body attacks those red blood cells, causing hemolysis, which is a medical emergency. Hemolysis is another word for red blood cell breakdown. So let's focus on the two blood types you absolutely must know for NCLEX. O negative is called the universal donor because its red blood cells have no A antigen, no B antigen, and no RH antigen. Since there are no foreign antigens for recipients' immune system to attack, O negative blood can be given to almost anyone during an emergency. So, especially when the patient's blood type is unknown. AB positive is a universal recipient. Patients with AB positive blood have both A and B antigens and the RH factor, so they can safely receive red blood cells from any blood type. For everyone else, remember this simple rule. Type A patients can receive A or O blood. Type B patients can receive B or O blood. Type AB patients can receive A, B, AB, or O. Type O patients can only receive from O. And finally, don't forget the RH factor. RH positive patients can receive positive or negative. RH negative patients should only receive RH negative blood whenever possible. So imagine your trauma patient arrives unconscious after a motor vehicle accident with severe bleeding. There isn't enough time to determine the patient's blood type. The blood bank will immediately send O negative packed red blood cells because they are the universal donor and can safely be given in an emergency. Later, once blood typing is completed, the patient is switched to their type specific blood. All right, so when it comes to hypervolemia, instead of too little fluid, hypervolemia means that the body has too much fluid, which is called fluid volume excess. Think about a patient with kidney failure. Normally, the kidneys filter excess water and sodium out of the body. But when the kidneys aren't working properly, they can't get rid of the extra fluid. So it stays in the bloodstream. As the amount of fluid increases, blood volume increases, forcing the heart to pump against a larger volume. Eventually, the extra fluid begins to leak out of the blood vessels and into the tissues, causing peripheral edema, such as swollen feet or ankles. Fluid can also back up into the lungs, leading to pulmonary edema, where the patient develops shortness of breath, crackles, and decreased oxygenation. All as nurses, you also notice weight gain, elevated blood pressure, bounding pulses, jugular vein distension, decreased oxygen saturation. The treatment is to remove the excess fluid by restricting sodium and fluids, administering diuretics, and in severe kidney failure, dialysis. So you have a patient with chronic kidney disease who has not had dialysis for several days. The kidneys cannot remove excess fluid. Fluid builds up into the bloodstream, blood pressure rises. The patient gains 6 pounds in 1 week. That's a problem. They need to come back. Their ankles become swollen. They become short of breath because fluid is now collecting in the lungs. This patient is experiencing hypervolemia and needs treatment to remove the excess fluid. So kidneys with chronic kidney disease, the kidneys can't remove the fluid. There's fluid retention. There's increased blood volume, increased blood pressure, edema, possibly pulmonary edema, respiratory distress. So another thing for you to understand is that daily weight is the most sensitive indicator of fluid gain. A gain of 1 kg or 2.2 pounds equals approximately 1 liter of retained fluid. You need to listen for crackles in the lungs. They are an early sign that fluid is backing up into the alveoli. Patients with heart failure, kidney failure, or liver disease are at higher risk of hypervolemia. The priorities are to reduce excess fluid, improve oxygenation, and prevent pulmonary edema, which can become life-threatening because now the patient's pretty much drowning inside. One of the simplest, most important nursing assessments is intake and output, or INO. It tells us whether the patient is taking in about the same amount of fluid they're losing, which helps us evaluate hydration and kidney function. Intake is everything that goes into the body. This includes anything the patient drinks, IV fluids, tube feedings, liquid medications, and foods that become liquid at room temperature, such as ice cream, gelatin, or popsicles. Output is everything that comes out of the body. The most important output is urine, but we also measure vomit, liquid stool, drainage from surgical drainage, or chest tubes, and blood loss. Intake and output should be recorded at least every 8 hours or according to your facility. You guys are lucky. We used to have to manually write intake and output, especially if it's strict. Luckily for you now, and we also had to calculate it by ourselves. Luckily now that you have computerized charting, you need to input all of that into the computer. Once you are able to do that, especially hourly, so that you don't forget, you shouldn't wait till the end of the shift to do it. But if you document it hourly in the chart, it'll automatically calculate it for you. Nothing is missed, right? So imagine a patient recovering from surgery. During one shift, they receive 1,000 mLs of IV fluids and drink 500 mLs of water for a total intake of 1,500. During that same shift, they produce 700 mLs of urine and vomit 200 mLs, giving them an output of 900. Since the intake is greater than the output, we should continue to assess the patient for signs of fluid retention, such as edema, weight gain, and crackles in the lungs. All right, so think back to our trauma patient. After blood loss, we closely monitor urine output. If urine output begins to decrease, it may be one of the earliest signs that the kidneys are not being adequately perfused because of hypovolemia. After giving IV fluids or blood, an increase in urine output tells us the kidneys are receiving better blood flow and the patient is responding to treatment. So what goes in must come out. Intake is oral fluids, IV fluids, tube feedings, liquid medications, ice chips. You count as half because their volume is half after melting. Gelatin, popsicles, ice cream. Output is urine, vomit, liquid stool, surgical or wound drainage, chest tube drainage, blood loss. So urine output is the best indicator for kidney perfusion. A healthy adult produces about at least 30 mLs an hour. We talked about that. We do daily weights and we evaluate fluid status. Never rely on one measurement alone. Combine intake and output, daily weight, vital signs, physical assessment, and lab values to get the complete clinical picture. So as we wrap up, remember these key components. Water moves by osmosis, while solutes move by diffusion. Electrolytes are essential for maintaining fluid balance, nerve function, muscle contraction, and heart rhythm. Hypovolemia means too little circulating fluid, while hypervolemia means too much. Choose the right IV fluid based on where you want water to move. And remember that albumin pulls fluid into the bloodstream. Finally, always assess the whole patient by looking at intake and output, daily weights, vital signs, lab values, and physical assessment. If you could answer, where is the fluid? Which way is it moving? And how to perfuse of how is perfusion affecting the patient, you will be prepared for both clinical practice and prepared to understand what is being asked for NCLEX. I really hope this helped. I'm sorry that this is very lengthy, but this is the best way to do it because sometimes our lecture classes is not enough. And this is something that you could go back to and maybe later on understand as you get into your clinical practice. Thank you. Bye.